let's finish going over this info in here. Okay, we should be on, we talked about pharmacokinetics. Let's talk about therapeutic classes of drugs. Should be on page 2 of your PowerPoint. Okay, and I'll just pull it up on here so you guys can go through it together. I can find it. Okay, let's talk about therapeutic classes of drugs. We'll go through here. Like I said the other day, when you think therapeutic, think therapy, treatment, and that's what we're talking about. So classes of drugs, different classes of drugs. When you're talking about a class, and like it said before, that it has a similar mechanism of action. And a lot of times they have a similar purpose. Okay, so their indication will be the same, or at least pretty close to the same. A lot of times their names will sound alike. So different classes of drugs, their names will sound similar. But usually they have the same effects, like it says on here, work the same way, but they may be made of different chemicals. So they can have different side effects. Some of them will be similar, some of them won't. Okay, this first one is called angiotensin converting enzyme inhibitors, or ACE inhibitors is what you'll see written, ACE inhibitors. Angiotensin, look, it says it's a vasoconstricting protein that regulates blood pressure. So we'll think vasoconstriction, vein, constricting veins. So it's a protein that constricts. So think about it. If it's a vasoconstricting, it constricts veins. Think about what that does to blood pressure. Okay, it's going to make it go up. Angiotensin is going to make blood pressure go up because it constricts your veins. Well, if it does that, blood pressure goes up. So look, this is a angiotensin converting enzyme inhibitor. Okay, so angiotensin converting enzyme is going to make angiotensin work. It's going to make it constrict. And if these medications are inhibitors, okay, it's going to keep that enzyme from working. So look, if given an ACE inhibitor, it inhibits or blocks that enzyme in the body. That's going to, so in turn, you're going to get a decrease in blood pressure because it's going to keep, or not necessarily a decrease, it's going to prevent an increase, basically. Okay, it's going to keep it open. So some examples of these: Acupril, Lotensin, Prenavil, Vasotec, Zestrol. Now, one thing to know, when I say that they're going to sound the same, okay, that doesn't necessarily mean that their generic, their brand names are going to sound the same. It means their generic name is going to sound the same. Let me find my next page so I can. Okay. So these, for example, whenever you see the generic name, it will have a pril or something similar to that at the end. Now, it's not 100% of the time on any of these, but that is the suffix for these classes of drugs. Okay, pril goes with ACE inhibitors. So ACE inhibitors is a blood pressure medicine, generally speaking. You take them for blood pressure. Okay, beta blockers. Beta-1 receptors are found in the heart and are stimulated by norepinephrine and epinephrine, which cause the heart rate to increase. Now, those of you guys in my anatomy class, you probably heard norepinephrine and epinephrine. We talked about that. We talked about the sympathetic nervous system. Okay, so these cause the heart rate to go up. Okay, so look, it says beta blockers bind to these receptors, causing them not to be stimulated. Okay, it blocks the norepinephrine, and the epinephrine, and binds them. So as a result, the heart rate is decreased as well as the blood pressure. Okay, so it makes it so that these receptors are not stimulated. It blocks them so that it can bring down heart rate, bring down blood pressure. So some examples of these: low pressure, think low press. low pressure. Kind of sounds like that. Tenormin, Toprol is a very commonly prescribed drug, Toprol. Usually the ending for these is O-L-O-L, O-L-O-L, okay? Metoprolol, atenolol. Those are going to be some names that you're going to hear, okay? O-L-O-L is the suffix for this. Metoprolol, atenolol, okay? Beta-2 agonists. Now remember we talked about antagonist and agonist. Agonist mean one that makes it keep doing what it's doing. So look, beta-2 receptors are found in the smooth muscles, specifically in the lungs. Okay, now remember we have smooth muscle that actually wraps around the bronchi, the rings inside the lungs. Okay, you got smooth muscle that's circular around the bronchi, the bronchioles. Because epinephrine is a normal hormone that causes dilation of the bronchioles in the lungs. Okay, so we talked about epinephrine being part of the sympathetic nervous system. Well, think about it. Okay, again, what happens when you go into fight or flight response? That sympathetic nervous system, okay, your heart rate increases, your blood pressure, your breathing increases, okay, those respiratory passages open up so you can take in more air because your brain needs more oxygen to work. So think that through sometimes when you're understanding how these work. So look, these drugs produce the same effect in the lungs as the epinephrine does. These are an agonist. Ventolin, Provenil, Ceravent, Alpent, Brethine, albuterol, okay? Those are all things that are in these beta agonists, okay? Sometimes you'll hear them referred to as bronchodilators. You might write that word down, bronchodilators, okay? But those are the beta-2 agonists. These are typically used for asthma, people with emphysema. They're used to open up the airways. Now look, side effects, tremors, increased heart rate, or insomnia. That's because they get epinephrine. It's same feeling as epinephrine, like adrenaline type feeling, okay? So their heart rate's going to be pounded really fast. They might get tremors just because, their heart rate's pounding fast, and they've got, like I said, it's kind of an adrenaline type rush. Okay, antihistamines. You guys have probably heard, go back to here. The suffix for beta-2 agonists is T-E-R-O-L. T-E-R-O-L. Now that's not always, it's not always the case, but you'll see that one, like albuterol, T-E-R-O-L. Okay, antihistamines. Because when a person is exposed to something they're allergic to, histamine, which is a chemical that we have already in our bodies, is released from mast cells in their body. Histamine receptors are then stimulated, and that's what causes the allergic reaction or the allergic symptoms. Okay? Because these drugs, antihistamines, bind to those receptors, but they don't stimulate their effects. So they reduce the allergic symptoms. So our body has this mass histamine release because our body doesn't like whatever the substance is. And so we have receptors that specifically, bind up to that histamine that cause the reaction. Well, these drugs will bind up to those receptors instead, which makes them not work, okay? So examples of these is Allegra, Benadryl, Claritin, Zyrtec, all those antihistamine, those allergy drugs that people take. So there's a couple of suffixes here. You guys can write them down just to keep them in your notes. Aramine, I-R-A-M-I-N-E, cetirizine, I think, is Zyrtec is an example. And then another one is T-A-D-I-N-E. T-A-D-I-N-E. The aramine, like diphenhydramine, that is Benadryl. You'll see that word sometimes. You guys ever look at Tylenol PM? Some people be like, I can only take a Tylenol PM just to make me sleep. But Benadryl doesn't work. If you look at the ingredients on Tylenol PM, it has Tylenol and it has diphenhydramine. Well, diphenhydramine is the generic name for Benadryl. So you know. Okay, H2 antagonists. Remember, antagonists are going to work against. Histamine is also triggered by food being inside the stomach. That's another example. This causes hydrochloric acid, that HCl stands for hydrochloric acid, to be released into the stomach. Histamine binds to histamine receptors. Now we're strictly talking about the stomach with these, okay? Don't think allergic reaction. Too much causes an increased amount of hydrochloric acid in the stomach, which can cause ulcers or GERD. GERD is gastroesophageal reflux disease. It's like chronic heartburn, okay? Or other diseases. So we have this increased amount of histamine in our stomach. Okay, our body just makes too much of it. Well, when it does that, then hydrochloric acid is overproduced as well, and that's what causes ulcers. That's what causes heartburn. It's that acid that goes up into your esophagus, and it shouldn't be there. So your stomach has this protective mucus lining on the inside of it, and that helps to actually protect your stomach from the acid that it secretes. Otherwise, that acid would just eat a hole in it. So if we have too much acid, then it can cause ulcers and ulcerate that because there's too much. So these particular drugs, H2 antagonists, block the histamine receptors in the stomach. So they block those receptors in the stomach. Some examples, Tagamet, Pepcid, Zantac. These are all like heartburn medicines. So whenever you hear them referred to, a lot of times you hear these, like you'll hear them in heartburn commercials or something. Okay. Proton pump inhibitors. Okay, stomach acid is produced by parietal cells that use hydrogen ions, and we'll talk about that when we get to the digestive system and anatomy, for those of you guys who are in anatomy. These medications turn off these pumps to decrease stomach acid. So these actually work on the pumps itself. It's a proton pump inhibitor, okay, in the stomach to help it decrease the amount of acid it produces. An example of this is Prilosec. So sometimes you hear all these heartburn medicines and you're like, oh, they're all the same. Well, some of them work very differently, okay? So this is an example. Prilosec works different than Pepcid. Now the suffix for proton pump inhibitors is R-A-Z-O-L-E, Razole, R-A-Z-O-L-E. And I didn't go, the suffix on these H2 antagonists is Tidine, T-I-D-I-N-E. It's kind of similar to the allergy one. Ranitidine, I don't know, there's lots of them, but ranitidine is the first one that comes to mind. I think that's Pepcid. Okay, narcotic analgesics. We've already learned a lot of these. Because our body makes pain relievers called endorphins. That's our natural way to relieve pain. And when endorphins bind to their receptors in the spine, then they inhibit the cells that carry the pain message to our brain. So think about that. We know those are sensory receptors. They meet up at our spinal cord and go up to the brain, and then the brain processes it as pain. Well, endorphins actually plug up those pain receptors and inhibit the cells that carry that message up. So these medications, these narcotics, okay, analgesic, remember, means without pain. Algesia or algia is pain, so an is without pain. Narcotic says these medications stimulate those same receptors to reduce the pain there. So they stimulate those same receptors. Very potent. Obviously, these are prescription only. You guys know that. Morphine, codeine, Demerol, Vicodin, Percodan, any kind of pain, narcotic pain medicine that we talk about, Percocet. Okay, NSAIDs, non-steroidal anti-inflammatory drugs. And you'll always see these written as NSAIDs, like it says on here. Non-steroidal anti-inflammatory. That means they reduce inflammation, but they're not steroids. Normally, to reduce inflammation, you would take a steroid. These are non-steroidal. So these can be used for pain or inflammation, so pain or swelling in the body are caused by chemicals called prostaglandins. Prostaglandin synthase is the enzyme that makes it. Okay, these medications inhibit the enzyme from making those prostaglandins. Okay, so it keeps it from making prostaglandins, which cause that inflammation, causes the pain. So you know these well: aspirin, Motrin, ibuprofen. Motrin and Advil are actually both ibuprofen. Those are the same thing. Relafin, Naproxen, Aleve. Typically, within this word, if you're looking at the generic medicine, you're somewhere in that word, you're going to see fen, F-E-N, or it could be P-H-E-N. But you're going to hear it in there somewhere. Now, aspirin is, it's kind of its own thing, but Motrin is ibuprofen, Advil is ibuprofen, Relafin, naproxen, naproxen, sodium, that same kind of sound. Naproxen is a leaf. Okay, a couple more. Reverse transcriptase inhibitors. I know this one sounds kind of crazy. Okay, it says your body uses an enzyme called reverse transcriptase to convert RNA to DNA. So think back to when you learned about cells, especially those of you guys in anatomy, and how RNA, remember, it like works kind of like a puzzle, and it goes to the DNA and it picks up the code from DNA, and then it goes and starts making proteins, right? The RNA makes proteins. Because in HIV, the virus's RNA invades the human cell and intertwines, which causes a change in the genetics when RNA produces DNA. So it changes the DNA. Okay, that's what HIV, it plugs itself in, if you will. These medications, so these reverse transcriptase inhibitors, inhibits this enzyme and decrease its activity, which slows down the spread of HIV in the body. So remember transcription in that process of the RNA making proteins. Okay, think about that. So examples of this: AZT, Combivir, Sestiva, Retrovir. A lot of times you'll see that word vir in there, V-I-R. That's a clue. Think virus, okay? If VIR is in there, acyclovir, think it's some kind of antiviral, and that's what these are. They're antiviral. They work on viruses. Okay, statins. This suffix is pretty easy because it's statin, okay? Lovastatin, you'll see it in there. Simvastatin. Our livers produce cholesterol in our body from our diet, okay? And this uses an enzyme it uses this particular enzyme to produce cholesterol. Well, these drugs, statins, actually inhibit this enzyme by decreasing the amount of cholesterol produced. Keeps your body from producing extra cholesterol. Most commonly prescribed drugs in the U.S. Most commonly prescribed drugs in the U.S. That's because of our diet. Okay, so some examples of these are Lipitor. Notice the lip in there. Think lipid, okay, fats, cholesterol, fats. So use that kind of knowledge whenever you're on these tests. Look at something. Think, if you see Lipitor, think, okay, well, that probably has something to do with fats because it sounds like lipids. So, that you can use that to narrow down some of your answers on these tests. Pravachol, you see cholesterol at the end of that. Okay, we're going to skip routes of administration until next week, or until later in the week. Okay, let's look at pharmacokinetics. Okay, pharmacokinetics, a study of processes that affect the blood level of the drug. So if you want to think of it this way, think of it as how this drug kind of moves in your body. It says it's a study of processes that affect the blood level of drugs. So drug treatment goal, the goal of treatment is to get the right amount of medication in your blood or your plasma concentration, that it works, but it's not toxic. Okay, so therapeutic effect. This is the level in the blood where the drug does what it's supposed to do, but not so high as to cause toxic effects. Okay, look, therapeutic range. This is the range of blood levels at where a drug is therapeutic, but not toxic. Okay, so it's working, but it's not toxic. And then other things that affect drug levels is your weight, liver function, so whether or not your liver can filter it out. Kidney function is another one. Age, gender, etc. Anything that's gonna work on metabolism can do that too. Okay, so there's 4 processes that affect the blood level of the drug. Okay, first we have absorption. Okay, how the drug enters in the bloodstream. So this is going to have a lot to do with the route of administration. So oral, usually it's dissolved in the stomach or the intestines. There's a few that can be dissolved in the mouth, and then they're diffused through the GI tract walls, just like food would be. Okay, they diffuse through the walls, like it's called diffusion. Okay, Due to diffusion being the process used, then there's not necessarily defined how it's going to go. Okay, so it just gets picked up and moves along the bloodstream. So absorption is impacted by how quickly the drug dissolves. So how fast does it, like baby aspirins, you can chew those up. Okay, so some of them anyways, you can. So those are going to get absorbed a lot faster than something that has like a coating, like enteric coated. And then how easily they can get through the walls of the GI tract. Okay, the second process that affects the level of drugs in the blood is distribution. This is where the drug goes after getting into the bloodstream, however it got there. It got there through the walls of the intestines, or if it was directly into the bloodstream, okay, but it's where it goes once it gets into the blood. So it can go to binding sites, so proteins in the blood, diffuses to other tissues, like it might go to fatty tissue, might go to cerebrospinal fluid, other areas where it needs to go. If tested, it says almost every fluid in the body will have at least a small amount of the drug, almost. Now remember, in the brain, there's a blood-brain barrier, and so a lot of drugs cannot get through to the blood that actually circulates in the brain. Okay, it says most of the time, only, not the blood that circulates through the brain, but the cells that are in the brain. Sorry. Most of the time, only a small amount of the drug actually goes where it is needed. So only a small amount of the drug actually gets to the place where you need it to be. Okay, the third thing here is transformation. So these are the chemical changes that take place in the body after absorption has occurred. So what change does it cause in the body? That's transformation. Mostly in the liver. It says some destroy the activity of the drug. So sometimes that can happen. And then elimination, so how our body gets rid of it. This is really important. If our body cannot get rid of the drug and we continue to take it, it's going to get to toxic levels in our blood. That's why kidney function is important and liver function is important. Process by which a drug is removed from the body, usually in the urine. Okay, hence that kidney function, like I said, but we get smaller amounts in the stool, sweat, tears, saliva, breast milk. A lot of it's excreted in breast milk. Okay, and that's that. That's pharmacokinetics. Okay, we'll be done for today. We'll get to dosages. Actually, let's just go over this really quickly. I just want to give you just kind of an overview. Okay, so dosages, it says dosage is just the amount of drug to be given. You have to know the therapeutic range, so, how many milligrams is enough, how much is too much, and then pharmacokinetic properties. Just because, if they have kidney disease, you need to know what's going to happen to that drug in their system. Usually, dosages, especially for kids, can be based on weight. You can't just give a kid an adult dose and expect it to work the same, because they may not be able to handle it. So other factors, that might affect the dosages, how it's absorbed, how it's eliminated, and so forth. A loading dose, okay, that's a little vocabulary term. This is a large initial dose to get the drug up into that therapeutic range. So they give them a loading dose. It might be, a multiple of what the normal dose would be, but it just gets them on up there so they can get started and get it at a good range. Then a maintenance dose is given after that loading dose. That's just the range to keep it going at its same level. Dosages, like it says, can include those processes. Percent body fat is important. Malnutrition, dehydration, again, liver disease and kidney disease affect how drugs, get through our body. We will get to systems of measurement in detail later on, but just to go over it in case you see something that goes along with it that doesn't make sense. Metric system is primarily what is used, okay? And it's much easier to use. Customary is like what we use: teaspoon, tablespoon, cup, gallon. All those are customary. Those are like our normal measurements. Avoirdupois, or I think that's how you say that. It contains a fluid ounce in the pound that we use. And then apothecary, it's kind of like an ancient one, but we still use a few things. Grains in particular, especially for like solid compounding, things like that. Again, metric, most often used in healthcare, gram, milligrams, milliliters, you'll see a lot of those. And then we'll go over this too real quick. Converting between systems happens all the time. You're always converting between different things. They may be pounds and kilograms or whatever. So make sure you guys understand, and we'll go through this. We'll actually do a whole unit on this. If you guys are having trouble with this, if you need to do this for your math worksheets, let me know and we'll go over it. But it's usually, until we really get into it, I'll do the teaching, we get to the math calculations. It should be fairly simple stuff that you've done before. So that's that, and we'll be done. And I hope you guys have a good day.